What we found out also is that apparently all the fight songs are about 1 minute long, which is just about right amount of time for us to make some some little technical transitions. So Saranga, you have you actually have four accounts. So we opened up all 4 accounts. So you should be able to share from any of those 4 accounts.
Oh, so hello everybody, and apologies, I had no idea I was so well represented on Zoom. Hopefully you can see my screen. Could somebody confirm if they can see my screen and hear?
Yes, we can see.
Yes, we can see your screen and hear.
Awesome, thank you so much. So I was asked to show IU Pride. So for those of you who can see me, I am presenting live from IU's newest campus, very fancy and fun, as you can see. My name is Suranga Kasturiratne. I am a computer scientist and informatician by training. I am pleased to present on behalf of my team members our proposal on the identification and mitigation of disparities in AI solutions built in response to the COVID pandemic. So starting off, we know that sometimes the deepest, darkest crisis forces humanity to push forward, innovate, and do better. Likewise, COVID has highlighted the potential of using AI systems to transform healthcare delivery for the better. Unfortunately, COVID has also highlighted awareness of significant systemic inequalities that are present across the US. There's documented evidence that talks about how there are significant disparities in terms of risk of exposure to COVID, risk of death, illness, vaccine hesitancy, and inequality of care. Ultimately, the optimal way to solve this problem would be to develop fair and generalizable models that can be used across a broad range of subpopulations identified by race, socioeconomic status, ethnicity, gender, or what have you. With that in mind, our team proposes to develop generalizable analytical solutions that are applicable to a broad range of populations across the state of Indiana, and then to identify and mitigate harmful biases within these models, making them more suitable for clinical use. So we are being very ambitious, but luckily we have a partnership with the Indiana Health Information Exchange that presents us the opportunity to be successful. The I.AIM is one of the oldest, most continuously operated HIEs in the US. It consists of over 100 separate healthcare entities representing 18 million patients. And these 18 million patients represent what truly Indiana is. They represent all counties, all zip codes, all ethnicities, races, genders, income levels, urban or rural divide, education level. They represent what it truly is to be a Hoosier. We leveraged the I.AIM dataset to build Codeco. Codeco is the COVID-19 research data commons. It is a subset of I.AIM patients who have been diagnosed with COVID. For these patients, we extracted everything available under I.AIM. We have their demographics, we have their clinical data, we have their social risk factors, medications, encounters, and data on various COVID-related outcomes. Additionally, Codeco is a living resource. We update it each week. We keep on iteratively revising and improving the data set. More recently, we also have access to Indiana's COVID vaccination records. So we are in the process of incorporating data on 4.1 million vaccine doses into Codeco to have a better picture of how the population is being vaccinated. Here's another high-level overview of the Codeco patient population. As you can see, we represent significant disparities in terms of gender, race, age, health status, and various outcomes. Now, we propose to leverage this excellent data set to build innovative predictive models that can be used to address key outcomes of significant concern. Obviously, this aim involves lots of machine learning. Our team has significant machine learning expertise in deep learning, random forest, decision trees. Despite of that, I won't talk too much about the actual machine learning activities. I do have a slide as backup, but I won't spend too much time on the jargon. Instead, I'd like to highlight several outcomes of interest. We would like to predict healthcare utilization, risk of long-term COVID-related outcomes, things like organ damage, mood changes, joint pains, and also risk of breakthrough infections. What patients are at risk of developing COVID even after being vaccinated. I'll outline some key challenges we expect to face. Determining the most appropriate feature representation, selection, and model development approaches for each use case. Understanding that the COVID data were collected at different stages of the pandemic, from the initial stages to shutdown stages, the enforcement and loosening of different restrictions, and increasing availability of vaccinations. The need to understand that each of these stages influenced how data was being recorded and how patients were being treated, and using it to influence the future of care delivery. Dealing with missingness and errors in the Codeco dataset. We know that often underserved patients don't present for care, their data is less available, there might be more errors. So how can we tackle this missingness and error? How can we ensure that the models are generalizable across all populations, that this model or series of models would work across the state no matter where it's used? At the end of AIM-1, we would have a series of machine learning models that deliver strong predictive performance. In AIM-2, we will systematically investigate these models for harmful biases and then address these biases so that no harm remains. There are several stages of this process. The first being to identify attributes that might influence disparities. For example, disparities might be influenced by demographic status, race, age, or gender, health status, your chronic disease burden, or social determinants of health, whether you live in an urban or rural area, whether you're unemployed or unemployed, whether you suffer from social isolation. So we will identify each of these attributes that must be investigated further. In the second stage, we will investigate each model for biases using a series of established bias detection metrics. The table presents several well-published bias detection metrics that are available. We will consider each of these methods to investigate biases across each attribute. The decision of which method to pick is based on the priorities for each use case. We will consider the context of each use case to pick the most appropriate method. Once harmful biases are identified, we will work to mitigate these biases. So a number of bias mitigation metrics are also available. We will consider each of these methods and explore their use in mitigating harmful biases. Obviously, biases cannot be truly removed, it can only be reduced. So we will investigate how to reduce harmful biases while retaining adequate predictive performance. Once again, the table that you're seeing outlines several key methods to mitigate harmful biases. They involve efforts to clean the data prior to model building, activities that one might undertake during the model calibration, and finally, attempts to correct model predictions once they are generated. So at the end of the second aim, we would have a series of predictive models that have been systematically reviewed for biases and have had any harmful biases mitigated, and as such are suitable for broader clinical consumption. Quickly, I'd like to highlight our team members. We represent a broad range of expertise from health data science, precision health, data quality, fairness and bias, UX design, and statistics. We also represent a full continuum of job expertise, or I guess career progression, from medical students to doctoral students, clinical informatics fellows, junior researchers, and senior researchers with national level reputation. In summary, I would like to highlight that we are a strong team of researchers with access to additional expertise from Indiana University and Regan Street Institute. We have access to a comprehensive, novel, and unique statewide dataset that is actively improved and updated. Finally, we have the potential to integrate successful models into clinical care processes where they can be used to improve healthcare delivery. In terms of scalability, our efforts will result in generalizable models that work across the state of Indiana. However, we see a potential pathway to influence US-wide initiatives. We actively collaborate in the NIH's National COVID Collaborative, where researchers have come together from across the US to bring together data from across the entire country and thus inform better analytical methods. They are in their infancy at this point. However, we hope that this work would influence and show the way for their oncoming initiatives. With that, I reached the end of my presentation, and I am happy to answer any questions. Thank you.
Great, thanks, Saranga. And so I think because it went over a little bit, we cut a little bit into time, so we have about 7 to 8 minutes for questions.
Oh, I apologize.
I have a question. So these models that you're building, what exactly are you predicting, and then how will it influence the patient?
Sure. So we have several broad outcomes in mind. We would like to refine them more as we progress down the idea and figure out what is possible and what is not. Right now, we are seeking to build predictive models that identify whether a patient is in need of hospitalization or ED visits. So based on the patient's past track record and their health status, would they benefit from immediate hospitalization or additional care? We also want to look at predicting whether a patient is at risk of more long-term outcomes. So you have the traditional COVID-based concerns, and then you have evidence that there might be other additional long-term effects: chest and joint pains, fatigue, depression, and other respiratory problems. So we seek to predict if we can identify patients at risk.
And this will go to the physician?
In the long term, yes. So we have expertise in incorporating models into direct clinical services. We've done that before. A successful model could be implemented directly into practice. A scenario would be where a patient is checked in and the model provides real-time information on the patient's risk. It has been done within IU health system before, and it can be replicated in this project as well.
Thank you.
Sorry, go ahead.
This work would have been really valuable at the beginning of the epidemic, but given where we are in the vaccination and all that, what do you see as the value to the people of Indiana given, all this work going forward?
So yes, I do understand that it would have been very important in the past. However, I don't think that discontinues the value for the future. We are providing a validated regulatory mechanism to hold providers accountable. If our models perform well and if they are de-biased, we provide a gold standard in terms of this patient presents higher risk. Why are you not giving this patient the same level of treatment or care that other patients get? From one part of the question, we do provide a regulatory mechanism. On the other side, we are preparing for any potential future concerns. In the event that a hospital is overburdened, if a provider has to make a quick decision, we provide a mechanism to inform their care to make a quick and accurate decision on how to guide care for patients that they are seeing.
Jumping in, as a practicing clinician in the clinic and in the hospital, I would continue to find predictive models for triaging patients and for identifying areas that I would want to focus on in the clinic or in the emergency department to manage, to evaluate more, to focus my evaluation and management on, quite useful. There are models for pneumonia that I use all the time to triage patients. I would find such a model for COVID-19 continually useful too. Whether right now we just have some very general risk factors, being able to identify what patients to focus on, whom to continue to manage as an outpatient, whom to schedule follow-up visits more frequently, whom to send to the emergency department right away, and whom to follow up closely over the long term too after the initial episode because of risk of chronic symptoms, as well as post-vaccination surveillance. Those I would find as a clinician all continuing to be useful, even if the pandemic is doing better now in the United States than in India, say.
I mean, that might be an area where you guys could focus. I think we know that the subsequent sequelae of COVID infection include mental health, as well as, the long haul physical manifestations. Certainly developing a model for who might be at risk and how you might successfully intervene would be valuable, as well as I really like the idea of breakthrough. Is there some pathogenic reason or some social reason why certain demographics might be more at risk for breakthrough, as opposed to a model to predict when somebody needs to be admitted? That just doesn't smell right to me. I mean, that's going to be a clinical decision. A model's nice, but if somebody's sick enough to be considered admittable or not, you're not going to be looking at an algorithm. You're going to be looking at SATs and chest x-rays and so forth. So I guess, how does this address disparities? I get that you have a model that you have the ability to generate models that incorporate lots of different opportunities to stratify by different socio-demographic cuts, but how specifically will this address healthcare disparities in your community?
So I can take a stab at that. So we are proposing to build a gold standard in terms of what potential biases can occur and how they can be rectified. For example, the presentation of disparity and bias depends on the use case. For example, if your model is assistive by nature, your understanding of bias is very different from what it would be if it was harmful. If your model outcome is that the patient gets $1,000, that's very different from the patient being sent to jail. So it's very context driven. We are seeking to bring together broad expertise to address key questions and then use these models as gold standards to inform uniform care across different systems. So ultimately, we are not only providing a triaging or screening solution, we are also presenting an accountability benchmark as to here's how you should treat this patient, here is the level of risk and type of risk. How should you take care of them, given that significant disparities have been found across the country?
the hope would be to allow clinicians to compensate for any biases that the model finds between populations and to correspondingly focus more attention on whatever disparities in outcomes occur there.